Okay. This is a very, very nice pleasure to introduce my close friend, Dr. Mangesh Kivaskar. I think he is known best as a little giant in the field of medicine, like Little Master Gavaskar, who has been extremely good speaker, a very knowledgeable person, and at the same time, very humble and very, very honest in his day-to-day activities. I know him since many years, and as a person, as a human being, he has a great qualities and is a fantastic human. And today he'll be speaking to us on Pioglitazone molecule. And just to introduce him, that he is a gold medalist in MD, MBBS, and he's Honorary General Secretary of National API ICP and PRF, Editor-in-Chief, Journal of Associated Physicians of India, Editorial Board of Medicine Update, International Journal of Diabetes, guest editor of the Insulite Journal, World Journal of Anemia, delivered plenty of lectures, more than 1,000, my God, great. 58 publications, various national, international journals, has multiple chapters, write-up, textbooks, update, MRCP examiner for Royal College of Physicians, UK. All these are his academic. More than that, he is a fantastic human being. Over to you, Mangesh.
Thank you, sir. And with humble charan spursh to you and appreciations to the organizers. Thank you for the beautiful opportunity. And it's always a pleasure and a privilege to get introduced by sir. It makes me always feel very humbled and absolutely honored when Neglur sir actually introduces. This topic of speaking about insulin resistance, I can tell you that this is one of the topics which is close to not only Dr. Panikar's heart, but as well as my heart as well. I'll tell you that the story goes long back. So as I thank organizers, also I would like to put my appreciations for our Paralympic medal champions. Organizers are very smartly, named the halls by the Olympic medalist. Now probably we'll have for now next conference, we'll name these halls by all these Paralympic medal champions. And now India's tally is probably 13 with 2 golds, 5 silvers and 6 bronzes, which stands till today morning. So I really appreciate the effort, and thank you, Neeta, thank you, Anjali, thank you, Sanjay, thank you, Neglur sir, and of course, Dr. Bansi and the entire team of IDEC for giving me this wonderful opportunity. Now, when it comes to Pioglitazone and the talks and the controversy, I still always, think, like this cartoon is saying, have we really understood the use of Pioglitazone in diabetes management? I believe yes. Yes, we have understood. It was approved by, the DCGI for the use of, sugar control in diabetes. And it was one of the insulin sensitizers that we used. But then everything was fantastic till 18th of June 2013. Everything was fine. The Pioglitazone was freely used. And then suddenly a GR was released. And we realized that, and this time I was there with Dr. Neglur sir and Dr. Panikar sir at Chicago ADA. And we were returning back, and on the airport, Chicago airport, when we were waiting for our aircrafts, and that day suddenly, we realized that the flight has been cancelled, and we were discussing, and the news came that Pioglitazone is banned to be sold in India. All its combinations in Pioglitazone was banned, and the cause was, of course, bladder cancer. We all knew about it, and thanks to this gentleman who created a havoc, he did, probably had a different intention to write down this paper, but it ultimately turned out to be a nightmare. And in a bargain, unfortunately, we lost one more beautiful molecule that we had in our TZD kitty, that was Steve Neeson. And this paper caught attention, which actually for a decade almost forced the controlling authorities to make it compulsory to have a cardiovascular safety outcome data before the drug got any approvals for the use. But then physicians of India, diabetologists of India, endocrinologists of India had a different opinion on this. And this ban, which was for the first time, this ban was unanimously defended, was argued viciously. There were multiple press conferences. I was also part of some of the press conferences along with Dr. Panikar and Dr. Neglur and Dr. Raju Kovil and so many others. And for the first time ever in the history of medicine, this happened, that the ban was lifted within the 3.5 months. And on July 31st, the ban was lifted back and the pioglitazone was again allowed. Now, why it is important? Because this is one drug which impacts the insulin resistance. This is one drug which is available for treatment of insulin resistance. And how it is important, we all are aware about it. And we all know that insulin resistance is the key component of type 2 diabetes and the management of type 2 diabetes. We all know that insulin resistance promotes atherosclerosis, it causes metabolic disruptions, it causes all the target organ damages, basically through a vascular damage or endothelial dysfunction that can be there. And what are the drugs that we have to treat such an important cause? Only two, pioglitazone and metformin. Let's discuss a bit in next 10 minutes or so about pioglitazone. We all know falls into a thiazolidinedione group of the moieties. You know, it activates a PPAR, that is peroxisome proliferator activator receptor gamma, and increases the transcription protein regulating the glucose and the lipid metabolism. We all know that there are three different PPARs, which are alpha, beta, and gamma, which are very important. We'll talk about PPAR gammas today. And by doing that increase in the transcription of the protein, it amplifies the action of insulin, not in the only liver, but also in the peripheral tissues. Remember that insulin resistance starts in liver and ends up in peripheral tissue. That is what the way the thiazolidinediones or TZDs, or especially pioglitazone, also acts by addressing this challenge. And that's how it improves the glycemic control. And there is no increase in the endogenous insulin secretion, which is usually seen with all the insulin secretagogues. Now, if you really compare both the I would say metabolic and the other effects of thiazolidinedione and metformin, you will see and you will realize that thiazolidinedione, especially pioglitazone, is probably scoring a little bit over metformin as far as all these parameters, which are actually the end outputs of the excessive insulin resistance. Look at the small dense LDL cholesterol particle size, the HDL levels, the triglyceride levels, the free fatty acid levels, the blood pressure control, the endothelial dysfunction, the inflammation reduction, and the beta cell health. Everything is beautifully addressed by TZDs. Let's see first how the beta cells and the beta cell mass is affected by pioglitazone. I don't want to go into the details about this HOMA beta cell feature study which was published, but you can clearly see that, you know, when TZD is there along with the control, in comparison to the control, you can see that the beta cell mass is better preserved. But this is fine in the clinical data. Do we have any evidence in the real world data? How would you know that whether it is truly happening or not? Just do simple tests. That is, you just try and estimate the plasma insulin levels and the pre-insulin levels, or the immature insulin levels, or pre-pro, or the split factors. And we all know that whenever there is an hyperinsulinemia and a beta cell stress, or whenever the sulfonylurea-like drugs, or I would say the insulin sensitizers, secretagogues, they act, they technically squeeze the beta cells. And in a bargain, along with insulin, there is a lot of output of premature, immature, pro-insulin, and sometimes pre-pro-insulin. You can clearly see this on the left side, where you can see that when these patients were given with glyburide, you can clearly see that there is a high amount of pro-insulin or an immature insulin also getting out from the beta cells. But whenever you give pioglitazone, either at the 7.5 milligrams per day dose or 15 milligrams per day dose, the beta cell rest is evident there. It has got a huge potential to offer a cardiovascular protection. And I'll tell you why. Why? Because it has not only have an ability to reduce down HbA1c to a tune of around 0.8 to 1.5, but also reduces down the small dense LDL cholesterol. So classical Indian hypertriglyceridemia, atherogenic dyslipidemia, what we know as, and also reduces down the triglyceride levels, causes rise in the HDL cholesterol levels, and also has got an ability to reduce systolic and diastolic blood pressure, and also reduces down inflammation. So sometimes, you know, I tend to compare them with SGLTs, and I'm going to show you that paper which was published. Now look at this HDL data that has come out. And this was published, you know, in the diabetes as a diabetes journal, because it was published as a ADA poster. And look at the impact on the HDL. When the HDL was above 35, that means that you never needed much of the rise in the HDL. Look at the amount of the HDL rise that pioglitazone has caused, 18%. But the moment HDL is low, that means the patient is high risk patient. where you need HDL to go high. Look at the rise, it is almost 32%. And it addresses this along with the redistribution of fat topography. It has got a beautiful ability to redistribute subcutaneous fat, and it causes the mobilization of fat from the from the visceral fat to the subcutaneous tissue, or I would say the redistribution occurs primarily by shifting out this numbers of the small adipocytes which are there. So TZDs will increase the more insulin sensitive number of small adipocytes. You know that whenever there is an obesity, the adipocyte size goes very large and they become more insulin resistant. And also TZDs, they better the triglyceride storages in the subcutaneous tissue and improves the insulin sensitivity. And this is what was taught to us by one of the most beautiful studies which was published almost a decade and a half ago, that was called as proactive study, which looked at pioglitazone and its outcome as far as the macrovascular outcomes are concerned. And this was a data of nearly 5,500 patients. And they looked at the patients which were high risk, like the patient, those who had a previous myocardial infarction or the strokes or an acute coronary events. And they really checked out the impact of pioglitazone. And what they found that this pioglitazone has reduced down the use by using pioglitazone, they reduced down the incidence of repeat MI by nearly 21%. Acute coronary stroke, acute coronary syndrome goes by 38%. Look at the stroke reduction by 48%. And that is the reason why at that time ADA was forced to come out with a statement that in one such trial, it appears that there is one drug which is offering you macrovascular outcome benefits. Now look at this paper which was published in 2019. This was a paper which was published by Raul DeFranco. And believe me, guys, Raul DeFranco is very, very fond of this molecule. And look at the last author, Steve Nissen. And they looked at the data from Periscope, IRIS, and Proactive and Chicago. And they have compared the data with SGLT2 and GLP-1 analogs. And look at this. This is pioglitazone data. Look at the 3-point MACE reduction by pioglitazone, 16%. Recurrent MI reduction by 28%. Stroke reduction by 47%. So you can see that every second patient is benefited, every third patient is benefited, every fourth patient is benefited. And if you really compare the outcomes, they are there with the SGLTs, you will be amazed to know that same 3-point MACE SGLT is reduced by 12%. Myocardial infarction, especially the secondary prevention, the SGLTs, they have a little poor score in comparison to pioglitazone. It reduces by 14%. Stroke, look at SGLTs where they are. Just reduction by 4%. In fact, one of the SGLT trials have shown the rise in the stroke incidence. And overall mortality goes down by 24%. So if you really compare these two head to head and just find out what is exactly happening, you'll realize that pioglitazone is not inferior to even SGLTs. Of course, SGLT, they do score over the heart failure related outcomes basically because pioglitazone has got a tendency to, give you a little bit of fluid retention. Same way, Chicago and Periscope has told us that it reduces down the macrovascular events by reducing down the carotid intima media thickness. Even Periscope has told that it even slows down the rate of progression of coronary arteriosclerosis. And this is the evidence that is by doing an IVUS, they found out in a mouse model that you can clearly see the administration of pioglitazone by just 15 milligrams dose. You can see that the carotid intima thickness has went down significantly. And it's not only effective just as a monotherapy, but in combination with all the other therapies. Now, why SGLTs are not there? Because when this paper was published, SGLTs they were not there in the market. So otherwise, they have shown the comparable benefits as far as the outcomes are concerned. Now, let's quickly see and understand what is the Mumbai experience, Indian experience. And this is Dr. Panikar and Dr. Shashank Joshi publishing the data of using pioglitazone in the triple therapy along with glibenclamide and metformin. Look at the drug combinations that they have used. And you can see the amount of the HbA1c reduction and the fasting and the prandial reduction, just the low dose pioglitazone that they have used. Now, looking at the bladder cancer, I had all my doubts, but let me tell you that the reported data shows what? 7 cases in 10,000 in the patients, those who did not use pioglitazone. This is the diabetic group of the patient analysis. People, those who have used pioglitazone, 8 cases out of 10,000. So do you feel that way? People, those who have used pioglitazone for 12 months, 10 cases out of 10,000. Guys, where we are. Now, if you look at the bladder cancer data, and if you analyze the global versus Asian population, as far as the bladder cancer incidence is concerned, you will realize that India has got the lowest frequency of bladder cancer, in the lowest in the Indian population. And even in the, not only the global population, but in the Asian population or an Asia-African population, you will see that India has got the lowest incidence. Look at this. The Caucasian, the frequency of having bladder cancer is 2 in 5,000, whereas in Indian, it is 0.24%. That is how low bladder cancers are. So overall, if you really look at the cancer outcomes in the patients, you'll realize that, in fact, the patients, those who had been using Pioglitazone, there were much lower incidences of liver, colonic, and lung cancers. It was remarkably quoted in a study of more than 6 lakh patients that Pioglitazone, when it was used, decreased the liver cancer by nearly 17%. It reduced the colorectal cancer by nearly 14%. Third, there was a 33% reduction in the lung cancer incidences in the patients, those who are using Pioglitazone. So remember that it's not Pioglitazone. Diabetes is a carcinogenic situation. And if you not treat diabetes adequately, you are likely to develop complications. I would say a follow-up data of proactive study, which analyzed the incidence of bladder cancer in the patients. And during the 4 years follow-up, they realized that there were no new patients of bladder cancer. In fact, they have realized that there were more patients of bladder cancer in the patients, those who are not using Pioglitazone, and in the placebo using people. Hence, American Association of Clinical Endocrinologists also came out with a statement saying that the clinicians should be confident enough to continue TZDs regularly. TZDs also have got a potential to delay the progression to type 2. So it has got some preventive abilities. And this is the paper which has been published by Durbin et al. And they have shown that whenever you are using this drug to prevent the progression from IGT to type 2 diabetes, it is extremely effective. So friends, Pioglitazone is the only agent available today that can effectively treat insulin resistance and preserve beta cells. And now I'll go further and say that possibly offer cardiovascular protection. There is a huge weight of evidence that it reduces down the insulin resistance, it preserves beta cell. There is a durable glucose lowering. It improves the lipid profile. It has an anti-inflammatory effect. Thus, it reduces down the cardiovascular. And remember that it is the only drug which has been approved to treat the non-alcoholic fatty liver disease, which is supposed to be the indicator of the highest insulin resistance. Of course, it does have some unfavorable effects like weight gain, congestive heart failure, bone fractures, bladder cancer. Yes, it has, but then a nice data which has been published by Dr. Panikar again has shown that if you use low dose Pioglitazone to a dose of around 7.5 to 15 milligrams, it gives you an effective glycemic control, but much lower unwanted effects, because the unwanted effects are usually the receptor dependent effect which they come in the higher dosages. So if you have got an receptor independent effects, it will improve the insulin sensitivity, it will reduce down the weight gain, it will reduce down the edema, and also will reduce down the negative cardiovascular outcomes. And hence, this was again the same Chicago ADA honor lecture we were listening when Dr. Neglur and I was there together, and we were listening, and Ralph DeFranco talked about TZD and Pioglitazone there. And he said that if you have got a durability of control over a long period of time, you know that you have preserved beta cell. That means that you have stopped the beta cell decline. And how it is important, this is DeFranco's Omnius Octet, and you can see that out of 8, almost 5 challenges are effectively addressed by TZDs. So friends, if it is insulin resistance, which is responsible for atherosclerosis, hypertension, dyslipidemia, obesity, endothelial dysfunction, coagulation or fibrinolytic defects, inflammation, type 2 diabetes, use TZDs, and everywhere you will have improvements happening at all the areas. So glitazones, and especially Pioglitazone, is one such drug which can actually change. So I'll end up my talk by saying that please use this drug and do not fall a prey to all those data which probably will need a little better understanding. Understand the beautiful lines which have been talked by our great late President Dr. APJ Abdul Kalam and Stephen Hawking, a technocrat, that a greatest reason for failure is not ignorance, it is the illusion of knowledge. Thank you very much. I'll say just Pioglitazone. If you do that, this Sholay dialogue, I remind If you don't use, thank you very much for your kind attention. You need to unmute yourself, sir.
The link, because I was told to talk after you because the next speaker is last moment cancelled. So I was trying to search my slides.
Oh, yeah. No problem. Perfectly fine.
So wonderful talk, Mangesh, as usual. And I think you have raised a very good issues. Some important point I would like to discuss with you is the Toskaity trial.
Yes, Tosca and Bari 2D.
This looked at 3,000 patients, Mangesh, and it randomized to receive either pioglitazone and sulfonylurea. And it was said that this trial was a negative trial in the sense that it showed that the heart failure was so high in these patients. So therefore, it was believed that this trial is negative. What is your opinion? Do you think this
Toskaity, yes, they used in the patient those who were, in a dose of 45 milligrams that they have used in Toskaity trial. And also Toskaity used, these patients, the drug in some very sick patients also. So I believe that, that there was a challenge as far as the choice of the patients and the choice of the dose is also. Yes, we do understand that pioglitazone needs to be carefully given and should never be given in the patient who is reduced ejection fraction with a, NYHA class 3 or 4 type of patients. Do not put them on that. But these are all clear indications. But in fact, if you realize that low dose pioglitazone up to the NYHA class 2 and class 3, you can easily give and be watchful as far as the fluid retention is concerned. And I'll tell you that, in fact, in few of my patients, my personal clinical experience, I have a lot of patients on pioglitazone and I've been using this low dose therapy. They've been doing fantastically well, even with an ejection fraction of around 20-25%. They're doing fairly fine if you're really observant and cover them adequately with other anti-heart failure line of therapy. You will have beautiful benefits. In fact, one of the papers which is going to come, and again, the Diffranzo and all this team is, and there are already a couple of publications which have happened as far as the combination of SGLTs and SGLTs plus pioglitazone.
Yes.
And it's a beautiful data which is coming up, which is being showing amazing results.
Right, very good. I think you're right, because this study, especially Toskaity trial, had only 10% of the patients with established cardiovascular disease, and 10% left the trial.
Yes.
It was a very badly conducted trial. And 28% stopped the drugs.
Yes.
Because at that time, the risk of bladder cancer was pretty high. So therefore, people stopped taking drugs.
Yes.
And therefore, and they also have event of 1.5 per 100 patients is quite low. So therefore, the entire study was underpowered. And therefore, I think it's important to realize that it is not the bad effect of pioglitazone, but it's a badly conducted study. And that's how I think you are right in saying that pioglitazone is the right drug at the right time, at the right place. I think one more point, I think you will agree with me, in the proactive trial. Now, if you look at today's modern cardiovascular outcome trial, you have 3-point MACE. Okay, and you show a superiority or a non-inferiority to placebo, so far as the 3-point MACE is concerned. What they look at proactive, besides 3-point MACE, they also included the peripheral vascular disease, which is very difficult to treat because of the presence of hypertension, presence of dyslipidemia and obesity. And that's the reason why the primary outcome was not significant. And the secondary outcome was significant because classically it was a 3-point MACE that we discussed in the modern cardiovascular outcome trial. Those days, there was no cardiovascular outcome trial those days. In 2005, when the study was presented, the birth of the Nissan controversy had not taken place. So therefore, we don't have any evidence or we don't have any data to say that this is truly a cardiovascular outcome trial. And one more point, I think you'll agree with me, Mangesh, that the inclusion criteria in the proactive trial They removed the patients who had a SGPT 2.5 times higher than normal. This was, I think, one of the mistakes.
One of the mistakes,
they did. That's why if they had kept those patients, perhaps
they could have even shown the benefit also
in terms of NFLD. So therefore, this is one bad point which was done in these patients. And you explained extremely well about bladder cancer, and there's a beneficial effect in terms of breast cancer and colonic cancer. So how can a drug which can benefit in some cancers can reduce the bladder cancer? So bladder cancer was again a bad kind of study which projected very badly about the ill effects of pioglitazone. What is your take on treating patients of neuroischemic disease without diabetes with pioglitazone based on the IRIS study? You think that is justified, or you think it is not justified? And if it works in those patients, what is the mechanism by which it gives benefit?
No, in fact, they are also probably, if you really look at as been metformin been used for the treatment of PCOD, where you are targeting there as an insulin resistance. Probably in the IRIS study also, when they have used, it was basically purely for its anti-inflammatory and the vasculoprotective effect primarily. And if at all you have some drug which is so cheap, so easily available, and has got such an effective lowering of the inflammatory markers, it stops the vascular, the smooth muscle proliferation. It reduces down the inflammation significantly. It also causes the redistribution and the improvement as far as the small LDL cholesterol is concerned, which is truly atherogenic dyslipidemia is corrected very well. Really, I believe that even whether there is a diabetic dyslipidemia or a atherogenic dyslipidemia, I will say this drug is going to be beneficial there also.
Right. I think you're right. This drug has proven beyond its capacity to control the blood sugar because it has reduced the intima media thickness. It also looked at the IVUS trial. You mentioned all those trials, and you said that there's definitely reduction in the atheromatous volume, and therefore all the arterial tree are kept open, and therefore there's no chance of any occlusive disease. But as of now, this study, base is not used in clinical guidelines to treat non-diabetic patients with pioglitazone.
Absolutely.
And when you talk of the glycemic reduction of the pioglitazone dose, it has to be at least 30 milligram. When you give 30 milligram, you get about 80% glycemic effect. That much glycemic efficacy. If you have A1C reduction of 0.75 with 45 milligrams, if you use 30 milligrams, maybe your glycemic efficacy goes down significantly, but you get the beneficial effects of insulin resistance, and it has the insulin sparing action, which you mentioned very elegantly and very rightly so. I think it was a wonderful presentation. But before we close, there's one more question for you in the chat box by Dr. Shantanu, who wants to ask you the combination of dapagliflozin with pioglitazone. What are your views on that?
That's what I was talking about just now. That there are new papers which are coming about, and I will not be surprised. I will not say that the fixed dose combination will be available. But we are already using pioglitazone along with SGLTs in our regular day-to-day practice. We surely are. But now with the data getting published, we'll also have an evidence. And I'm sure that why pioglitazone is not explored too much because of all this too much of talking. And unfortunately, pioglitazone is not, I would say, so easily used in the Western or the Caucasian population. But
I think it's got a bad publicity, yes.
Yes, and in the Asian population, probably pioglitazone is one of the wonderful drugs because we have a very high incidence of insulin resistance. So it's going to be an amazing. In fact, sir, I'll say that if Proactive would have been powered for superiority, that would have been ended up as a superiority trial, first superiority cardiovascular trial.
Yes. If you remove that peripheral vascular disease, I think maybe you would have got all the points in your favor, including the primary outcome.